Okay, I
Okay.
think some of the
Okay,
audience...
you all carry on then. It must be something on my side. Please go ahead.
Oh, okay, sounds good. Yeah. Just to start over again, good evening and welcome everyone to this educational webinar on colon health and colon cancer prevention. And thank you for being here today, and we hope that you are staying safe and healthy. And my name is Neeta Dhananjaya. I'm a physician, a part of the Health Awareness Committee of Indian American Medical Association of Illinois. And COVID-19 has kept us all busy, but we still need to pay attention to some other preventable health issues and diseases. And colon health and colon cancer screening is one of them. And we are very thankful to the Schaumburg Township Public Library for working with us in bringing this educational webinar to the patrons of the library and to other audience. And to provide us with the most up-to-date information, we have Dr. Anna Patel. Dr. Patel is a board-certified gastroenterologist. She's affiliated with Amita Healthcare and also Resurrection Medical Center and Community Medical Center. She specializes in colon cancer screening, liver and biliary tract diseases, and pancreatic diseases, and other gastrointestinal disorders. Thank you, Dr. Patel. We truly appreciate you taking this time to provide us this educational webinar. And without further delay, we would like to start the program now. And I would like to request all of our audience that at the end of the talk, we'll have a brief Q&A session. And please, if you can type in your question in the chat box or in the Q&A link, we'll try to answer as many questions as possible. And lastly, I would like to remind everyone that this is an educational, informational session only. If you or your loved ones, if they are having any colon issues or gastrointestinal issues, please see your primary healthcare provider. So that's from me. And then welcome, Dr. Patel. You can take over. You can start the presentation. Thank you.
Thank you. Thank you for such a nice introduction, Dr. Dhananjaya. Good evening, everyone. My name is Dr. Anna Patel, and I am a gastroenterologist. I'm on staff at Community First Medical Center, which is located in Chicago, as well as several hospitals also in the city, which are affiliated with Amita Health. Tonight, my presentation is on colon cancer prevention and ways to improve colon health. So let's get started. Okay, so in February 2000, President Clinton officially dedicated March as National Colon Cancer Awareness Month. Since then, it has grown to be a rallying point for the colon cancer community, where patients, survivors, caregivers, and advocates throughout the country join together in order to spread awareness about colon cancer. As you can see, blue is the color for colon cancer awareness. Fundraisers and educational events are held, and we spend the year talking to friends and family about screening, but really so a lot more in the month of March. Okay. This is just a slide where I wanted to illustrate that colon cancer affects anyone and everyone. Unfortunately, everybody can be affected by colon cancer. And so you have in the top corner right here, this is Charles Schultz. This is the gentleman behind the comic strip Peanuts. And he was diagnosed with colon cancer and passed away shortly thereafter in the year 2000. You have Darryl Strawberry, a famous baseball player, was diagnosed with colon cancer at a very young age, at age 36. We have Audrey Hepburn, who passed away from colon cancer. Ronald Reagan also had colon cancer and underwent surgery to have parts of his intestine removed. He beat the cancer. This is Elizabeth Montgomery, the actress well known for the TV show Bewitched. We have Sharon Osbourne here, who was also diagnosed with colon cancer and is in remission. Ruth Bader Ginsburg, who had several cancers, one of which was colon cancer. Vince Lombardi, well known as the longtime Green Bay Packers coach. And then finally, not Katie Couric, but her first husband, Jay Monahan, passed away from colon cancer. Katie Couric has done a lot of education about the disease. Then on this slide here, as you know, all of us know, more recently, the actor Chadwick Boseman passed away from colon cancer. He played the Black Panther in the Marvel movie. He died at a very young age, at age 43, in last year, in the year 2020. So as you can see, unfortunately, colon cancer does affect all of us. Okay, so what we will be discussing today is what is colorectal cancer, how common is colorectal cancer, causes, risk factors, and prevention of the disease, screening guidelines, early detection, diagnosis, and staging of colorectal cancer, treatment, and then what to expect after you've been treated for colorectal cancer. So before we get started, it's important to understand the anatomy. So the colon is a muscular tube. It's about 5 feet long. It's part of our digestive system. It absorbs water and salt from food, and it stores waste matter. And if you can see my mouse here, I'm going to outline right here. That's the colon. And then at the very bottom, you have the rectum and anal canal. That's about the last 6 to 8 inches of the digestive system. And the anal canal ends at the anus, which is right down here. And that's the opening of the large intestine to the outside of the body. So cancer is the growth of abnormal cells. Cancer cells invade and damage normal tissue, and colorectal cancer is cancer that starts in the colon or in the rectum. So how common is colorectal cancer? So this slide presents estimates for this year. So the estimated new cases in the year 2021 of colorectal cancer will be about 150,000. That makes up about 8% of all new cancer cases. The estimated deaths from colorectal cancer this year will be about 53,000. That makes up about 8.7% of all cancer deaths. In regards to estimated cases, you can see that colorectal is, for both male and female combined, it is 4th on the list under breast, prostate, and lung. And then in regards to deaths, colon cancer is the second leading death from cancer behind lung. This slide, really, I just wanted to use it to show where we are as a state. I have the state of Illinois blocked off here and then here. The data is a little bit old, but it just gives you an idea that in terms of incidence, which is the rate or frequency of colorectal cancer, you can see that as it gets to a darker shade of green, the incidence increases. So in the Midwest, we have a higher incidence of colorectal cancer compared to, let's say, the West Coast. And then in regards to mortality, again, in the Midwest, we do have a higher rate of mortality in comparison to some of our other neighboring states on the coast. So you can see we still have a ways to go. How common is it? So colorectal cancer is a preventable disease. The American College of Gastroenterology, even their most latest guidelines from this year, recommend colorectal screening in average risk individuals beginning ages 50 all the way up to 75 to help to reduce the incidence of polyps, especially precancerous polyps, colon cancer, as well as reducing the risk of mortality or death from colorectal cancer. So those are strong recommendations made by the American College of Gastroenterology. The same group, ACG, or American College of Gastroenterology, makes a suggestion, however, that we should really start to screen people at even younger than 50. And that age that they want us to start screening at is age 45. So again, the recommendation is to start at 50, but it is a suggestion that screening start at a younger age. The reason is because screening tests such as colonoscopy, which we'll discuss in a little bit, helps to prevent colorectal cancer by finding precancerous polyps. And more than half of all colorectal cancer cases could have been prevented by regular colonoscopy screening. Next, we're going to move on to causes of colorectal cancer. We don't know the cause of most colorectal cancer, but the most likely cause is related to changes in our DNA, so in our genetic material in our cells, and our lifestyle also can play a role in predisposing us to colorectal cancer. So in regards to colorectal cancer risk factors, a risk factor is anything that raises your chance of getting a disease, such as a cancer. Different cancers have different risk factors. Some risk factors, like smoking, can be changed. Other risk factors, such as your age, your family history, you don't have control over it. It can't be changed. So the first colorectal cancer risk factor I'm going to talk about is age. Most colorectal cancer occurs in people 50 or older. The average age of diagnosis is 72. 90% of new cases and 95% of deaths from colorectal cancer occur in people at age 50 or older. The good news is that while rates of colorectal cancer in adults 50 or over are coming down, the rates are declining. Unfortunately, the rates of diagnosis of colorectal cancer in younger people, so people less than age 50, is increasing. So again, another reason to push for colorectal cancer screening at a lower age, at age 45. We know that a diet that's high in red meats and processed meats raises your risk of colorectal cancer. A diet that tends to be higher in fruits and vegetables lowers your risk of colorectal cancer. I have had patients tell me that, I don't need to have my colonoscopy done. I don't need this done. I'm a vegetarian. I don't get colon cancer. And that's not true. So vegetarians do get colorectal cancer. We just know that that you will have a healthier colon if you eat more fresh fruits and vegetables, as opposed to more carbohydrates and more processed type foods. Other risk factors include physical activity. So the less active you are, you do raise your risk for colorectal cancer. Obesity raises your risk of having and dying from colorectal cancer. Smoking, alcohol, and type 2 diabetes also raises your risk of for this disease. And that shouldn't be a surprise. A lot of these things raise your risk for all types of chronic medical conditions, not just colorectal cancer. There are specific at-risk populations. We know that African-American men and women do have a higher risk of developing colorectal cancer and a lower survival rate. So there is approximately a 20% higher rate of development of colorectal cancer and a 45% higher mortality rate compared to Caucasians, Asians, Hispanics, and Native Americans. The reason for this is disproportionate screening. We just don't do a good enough job of capturing these patients. And then also genetic factors are thought to play a role. Experts in our field do suggest that we start screening African Americans at age 45. Now, some adults have risk factors that make them a lot more likely to develop colorectal cancer than others. So one group of patients are those with inflammatory bowel disease. Inflammatory bowel disease is kind of a big umbrella term. Underneath that heading, the two main diseases are ulcerative colitis and Crohn's colitis. These are both inflammatory conditions that affect the colon. Ulcerative colitis is within the colon. Crohn's disease can actually affect anywhere in the digestive tract. So that includes the stomach and small intestine. And we know that these patients, the longer they have inflammatory bowel disease, the higher the risk of development of colon cancer. So these patients need to have regular screening done. Irritable bowel syndrome, otherwise known as IBS, is not a risk factor for colorectal cancer. Other major risk factors include people who have had adenomatous polyps. Adenomatous polyps are considered precancer, or who have had a personal history of colon cancer. Other major risk factors include even a family history of adenomatous or precancerous polyps, as well as colorectal cancer. There are certain inherited syndromes that are linked with colon cancer that do put people at a higher risk of development of the disease. And those inherited syndromes in particular, there's two of them. One is called Lynch syndrome, which is one of the most common hereditary colorectal cancers. It accounts for about 2 to 4% of all colorectal cancers. And cancers linked to the syndrome tend to develop when people are young. So people with the Lynch syndrome can have polyps, but they tend to have only a few polyps. But those polyps, or at least one of them, will turn into a cancer. The second inherited syndrome, which is well known, is called familial adenomatous polyposis, or FAP for short. This accounts for about 1% of all colorectal cancers. These patients tend to develop hundreds upon hundreds of polyps throughout their colon. It starts at a very young age, about 10 to 12 years old. Cancer usually develops in one or more of these polyps as early as age 20. And by age 40, almost all people with this disease will have developed colon cancer. So, these few things that I spoke about, the inflammatory bowel disease, the personal history of colon cancer, precancerous polyps, these inherited colorectal syndromes, these are all considered major risk factors. And the other risk factors, such as, your weight, your lifestyle, your age, those risk factors, just because you have them does not mean you will get colorectal cancer. So again, by having a risk factor, or even many risk factors, does not mean you will get the disease. However, we know that there are people who don't have any risk factors and still develop colorectal cancer. So again, it's another reason why screening is important. Now, if you have any of the major risk factors that we spoke about, it is important that you do share that with your doctor, because it may affect or change your particular screening, meaning you may have to start at a little bit of an earlier age. Next, we're going to be talking about polyps. You've heard me mention that word several times. So a polyp is a growth of tissue in the lining of an organ. So this is just a picture, if you can see my mouse, of the colon. And within the colon, you can see these little round balls, and that's what a polyp looks like, actually. So there's a little magnified picture here of what a polyp looks like. And when we do colonoscopies, we really run into two main types of colorectal polyps. One is called a hyperplastic polyp, and there's a very small chance that these polyps will grow into cancer. The second type of polyp is the adenomatous polyp, and that is considered a precancerous polyp. So most colon and rectal cancers start out at these adenomatous polyps, or adenomas, as we like to call them for short. So when we do colonoscopy, we actually remove all of the polyps that we see. The reason is because we cannot tell 100% by just looking at the polyp what kind of polyp it is. There's another physician called a pathologist who actually looks under the microscope and can diagnose the type of polyp that a person has. So here is a picture kind of the development of a normal colon, a polyp, all the way to a colon cancer. So this picture where my arrow is, or where my mouse is, this is a normal colon. This is a picture of a polyp. It's an adenoma. It's been identified as an adenoma. And you can see that this polyp has a growth, a stalk here. And then the growth here is the polyp. So the top of the stalk is the polyp. And when we do colonoscopy, it's the polyp that we remove. The stalk is actually left behind. The stalk is not an adenoma. It's actually normal tissue. So it's just the head here, the polyp that's removed. And typically these adenomas are very small. They start out by just being a few millimeters in size, but over time they do grow larger, and this is what a colon cancer looks like. Okay, so this is development into a cancer. Colorectal cancer signs and symptoms. There's various different signs and symptoms. I will go through a list of them. One of the things to remember is that the following signs I go through can indicate colorectal cancer, but they can also be seen in other types of diseases affecting the colon, not necessarily cancer. So the things we get concerned about, or we call alarm symptoms or red flags, are blood in the stools. That's not getting better. Narrower than normal stools. So they could be described as thin appearing stools, or sometimes people say they look like pencils. They're that thin. Unexplained abdominal pain. Change in bowel habits. So if you're a pretty regular person and all of a sudden you're having a lot of diarrhea or constipation that's developing over time and it's not getting better, that's of concern. Anemia, unexplained anemia. Anemia is low blood count. Unexplained weight loss. Typically people have an appetite, they feel like they're eating, but they're just losing weight. So again, those are alarm symptoms. However, colorectal cancer can be present in people that don't have any symptoms, and that's why we do a screening test, is to prevent the development of colorectal cancer, to prevent people, because once they have these types of symptoms, you get concerned that perhaps a colorectal cancer has already started to develop. We're going to move on to screening and detection. So regular screening can help to prevent colorectal cancer through diagnosis at an early curable stage. So that means people that have a very early colorectal cancer, it can be removed easily. Or through removal of precancerous polyps, which are the adenomas. So you're removing the precancerous polyps before any cancer develops. Adults ages 45 to 75 should be screened for colorectal cancer. The decision to be screened after age 75 should be made on an individual basis. So people older than age 75 who have been getting regular colon cancer screenings since age 50 and who have had consistently negative screening, so no polyps, in particular, no adenomas, no personal history of colon cancer, these patients are not at increased risk of colon cancer because they have a very benign family history, may not need to get continued screening. However, we do tell our patients that, many people live very long, productive lives. They have a very good quality of life. That, if you're somebody that's going to live well into your 90s, you should think about having your routine colonoscopy even after age 75, because removal of any precancerous polyps may make a change to your quality of life. So our patients that are healthy, a lot of them do choose to continue with their colon cancer screening even after age 75. So again, this is something that needs to be made on an individual basis, a discussion with your doctor. There are several different screening tests that can be used to find polyps or colorectal cancer. So how do we do colorectal screening? So the best way to think about it is that there are tests that can detect polyps and colorectal cancer. And then on the other hand, there are tests that mainly find cancer. So they're not good at finding polyps. They are used more to find when the cancer has already developed. So tests that can find both polyps and cancer. I've listed 4 tests here. First is what's called flexible sigmoidoscopy. Second is colonoscopy. third is double contrast barium enema, or DCBE for short. And CT colonography, which is also called virtual colonoscopy. So I put an asterisk by flexible sigmoidoscopy as well as the last two, because if anything is found on these tests, the patient should be referred for a colonoscopy. So these tests look inside the colon to find abnormalities. And the techniques are different. So the flexible sigmoidoscopy and colonoscopy do use a scope, so a small thin tube with a little light and camera that's put in through the rectum. And then the other two are considered radiology tests. So they use imaging such as X-ray or CT scan. If polyps are found, they can be removed before development into a cancer. So these tests help to prevent cancer. Okay, so colonoscopy again is a thin tube with a little light and camera. It's put in through the anus and rectum and passed up into the colon to look for abnormal areas. And what's nice about colonoscopy is if any polyps are identified, they can be removed at the time of the colonoscopy. This test is done under anesthesia. It's like a twilight anesthesia. So it's like being in a nice nap. The patient is breathing on their own. Their blood pressure, heart rate, oxygen levels are all being monitored. It's a short test. It's about 30 minutes on average. If a patient has many polyps, obviously the test will take a little bit longer. And then if you look here, this diagram, this is the colonoscope, and it's entering the anus and it's going all the way through the colon, all the way to the top here. Now, flexible sigmoidoscopy uses the same technology. It is a thin scope, a thin tube with a little light and camera. However, a flexible sigmoidoscopy also goes in through the anus, but it's only good at looking at about a third of the colon. So there's 2/3 of the colon you are not seeing. So in reality, most of us do not recommend flexible sigmoidoscopy as a screening test. We actually recommend colonoscopy. So this is a diagram of kind of what it looks like from our end when we remove a polyp. So what you have here, this is the colon. This is the inside of the colon. This round ball here is the polyp. This is our little light and camera. And what we're doing is we pass instruments through that colonoscope. So you can see an instrument coming out and it has gone around the polyp, and then it will just clip the polyp right at the base. And then it's removed. So we can use these tools to pass through the scope to remove the polyps. And by removing these polyps is how we prevent colon cancer. So we remove these polyps before they can turn into a cancer. So with the pandemic, how has colonoscopy changed? So what is an outpatient colonoscopy now in the setting of COVID-19? So beginning last year, in about April of 2020, the Illinois Department of Public Health, or IDPH, did set forth guidelines. The IDPH does require preoperative testing for COVID-19 within 72 hours of the scheduled colonoscopy. And typically it is a nasopharyngeal swab PCR test. So it is almost that long Q-tip that goes in through the nostril, tickles the brain. That's the test that's done about 72 hours before your colonoscopy, and patients are then asked to quarantine for those about 3 days. Even if you're vaccinated, it is still required to have the test done before the colonoscopy. The Pcr test is what we call it's a molecular type of COVID-19 testing. It stands for polymerase chain reaction. It's a very sensitive test, and it does take a little time to come back. So it's not a rapid test. A rapid test tests for antigen, and it's just not as sensitive as the PCR test. So bottom line is you will be getting a swab done a few days before your colonoscopy. When you enter the facility, whether it's an ambulatory center or a hospital, you get a temperature check. So they're looking for a temperature less than 100.4. Everybody has adequate personal protective equipment. So that includes the staff. The patients are given masks to wear. There is strict infection control, so staff also undergo screening every day. We all get our temperature checked. Visitors are generally prohibited. So as you know, in the past, when you came for your outpatient colonoscopy, you needed somebody there waiting for you to take you home. Because of the anesthesia, you are not allowed to drive home or go home by yourself. Now your friend or family member will not be able to wait at the facility. They will just come pick you up when your procedure is done. If there's a waiting room area in the facility, you will now see that the furniture is spaced apart or seats may be blocked off so that nobody is sitting close to one another. Equipment is sterilely processed, which it always was. So that has not changed. Everything is sterile. And then there's no mixing of COVID patients with non-COVID patients. So these are areas that are all what we call non-COVID care zones. So those are the some of the things that are now in place for outpatient procedures, including outpatient colonoscopy in the setting of COVID-19. Let me see here. So the last two tests I wanted to talk about that detect polyps and cancer are more radiology type tests. So the first is double contrast barium enema. So barium is like a chalky white substance, and it shows up white on an x-ray. So remember, this is a radiology test. It's a picture test. And what the radiologist does is they put a little plastic tube in through the rectum. And if you look at this diagram, this is the plastic tube here. And they put barium through that. It fills the colon, and then they do a series of x-rays. They can actually detect polyps. They can look at the size of the colon. They can look for any growth of polyps. If you look at this small box here, this white here, this is the barium filling up the colon. So again, this is a picture test. And then finally, there's CT colonography, another type of radiology test, a picture test where air is actually pumped into the colon through a small tube. And then it does employ CT scan technology to take pictures of the colon, and special computer programs are used to create views inside the colon and rectum. And that's the radiologist is trained to read for polyps. Again, in the majority of our practices as GI physicians, we really go to colonoscopy as our main screening test. These radiology tests like CT colonography, the double contrast barium enema, those tests we kind of use in our armamentarium. For instance, if somebody can't tolerate a colonoscopy, or it was a very difficult colon to try to get all the way to that right side of the colon, then we may fall back on these other tests. But first and foremost, we do recommend a colonoscopy to help detect and remove polyps, and also for detection of colon cancer. Now we're going to move on to tests that mainly find cancer. So the other tests I spoke about, again, find polyps and cancer. These tests do not look for polyps. They cannot detect polyps. We use them to help to detect cancer mainly. The three tests I'm going to talk about are the guaiac-based fecal occult blood test. Number 2 is the fecal immunochemical test. And then the third is stool DNA test. So what these tests look for are hidden or microscopic amounts of blood or other changes, including even at the cellular level, that could indicate colorectal cancer. Now, these tests are less invasive, meaning that they don't require anesthesia. They don't require the use of a scope, so no little light or camera, no machinery is involved, so they're easier to do. Again, these tests are less likely to find polyps than the other tests that I had previously mentioned. But again, if any of these tests come back abnormal, the patient needs to be referred for a colonoscopy. So the first test is the guaiac-based fecal occult blood test. It uses the chemical guaiac to detect occult, which is hidden or microscopic amounts of blood in the stool. So, you don't see the blood in the stool. It's the use of a chemical which actually turns blue. And that's what this picture is showing here, that indicates that there's microscopic or occult blood. Now, this test can be affected by certain medications and foods. So your doctor may tell you that you need to stay away from certain fruits or vegetables. I know broccoli is one. I think red meat as well. It can affect the result. It can indicate that blood is present even when it's not, or vice versa, or can miss the presence of blood. Certain medications such as anti-inflammatory type medications, antiplatelets like aspirin, blood thinners, because these medications can cause a little bit of bleeding in the digestive tract, it could get picked up on this guaiac-based fecal occult blood test and give a false result. You know, it could be just the medication causing a little bit of bleeding in the digestive tract, not necessarily a polyp or a cancer. This test cannot tell if the blood is from the colon or from other parts of the digestive tract. So it can't tell you if it's blood coming from the stomach versus the colon. But you can do this at home. You just use a little stick or a brush. You obtain a small amount of stool and you just smear it on the card. You bring back the cards, and usually we do 3. You bring it back to your doctor or to the lab, and then they put a little chemical on there to check if there's any microscopic or occult blood. The second test is the fecal immunochemical test. It tests for occult or microscopic blood in the stool in a different way than the guaiac-based test. So this fecal immunochemical test reacts to part of the human hemoglobin protein, which is found in red blood cells. The nice thing about this test is that there are no drug or dietary restrictions. It's less likely to react to bleeding from other parts of the digestive tract, such as the stomach. So it's a pretty good test to look for bleeding specifically from the colon or large intestine. The process is pretty similar to the guaiac-based fecal occult blood test. You do need to take several samples, and you can collect it at home and bring it into your doctor's office. The stool DNA test, the most well-known is called the Cologuard, and it detects altered DNA in your stool. So every day, the lining of your colon naturally sheds cells. So if you have cancer or precancer in your colon, those cells, those abnormal cells are shed into your colon along with the normal cells. They get picked up by the stool as the stool passes through the intestine. So the Cologuard does require that you collect an entire bowel movement. You also collect a small scraping. You do it at home and you package it and you send it back. And they give you everything in a kit, and it's sent back to a lab to check for cancer cells. It is a good test. A positive result could indicate the presence of colorectal cancer, and it can also detect polyps, especially the precancerous polyps. Again, if your Cologuard comes back positive, you need to have a colonoscopy. So to give you some statistics, in a study of 10,000 people of average risk for colon cancer. So remember, if you're average risk, you don't have a family history, and you yourself have never had a personal history of colon cancer or a chronic colon condition like inflammatory bowel disease. So you're an average risk patient for colon cancer. Cologuard found 92% of cancer in these 10,000 people that they studied. It was negative in 87% of patients without cancer or an advanced precancerous polyp or adenoma. So again, it is a good test. We see it a lot. A lot of primary care doctors do use this test, especially for patients that may be hesitant to undergo a colonoscopy, but willing to do so if this test is positive. So there's a variety of reasons why people are getting a Cologuard test. However, it's not a replacement for colonoscopy in high-risk individuals. So if people have any of the risk factors that we had previously spoken about, especially the major risk factors, they need to just proceed directly with a colonoscopy. Now we're going to move on and talk a little bit about colorectal cancer treatment. So, treatment for colorectal cancer is the most effective when the cancer is found early. And colorectal cancer treatment can include a combination of surgery, radiation, and or chemotherapy. And we'll talk a little bit about other treatments that are called targeted therapies, which are a little bit different than chemotherapy. So there are different ways to treat colorectal cancer. It depends on the type of cancer and the stage. So by type, I mean, is it colon or rectal cancer? And then the stage is the extent of the cancer in the body. So what is looked at is the size of the tumor, whether lymph nodes contain cancer. So lymph nodes are these bean-like structures. We have them all over the body, and including around the colon. They help with our immune system to protect us from infections. So we look at those lymph nodes to see if they contain cancer. And then we also look to see whether colorectal cancer has spread to other parts of the body, including to other organs. So there are 4 stages that we look at. Stage 0, and if you want to look at this diagram, here is stage 0 here. And you see a little growth, and it's in the inside of the colon. So it's a very early cancer, and it's in the innermost layer of the intestine. Stage 1 is now the cancer not only is in the innermost layer, it's starting to grow within the lining of the colon. So it's spreading a little bit within the colon. Stage 2 is now the cancer is growing into the muscle of the colon. Stage 3 is when the cancer is now growing into those lymph nodes, those little bean-like structures. And then stage 4, which is right here, and this is where this arrow is indicating, is that the cancer is now spreading to other organs. So we have local versus systemic therapies. Local treatments treat the tumor, the colorectal cancer, without affecting the rest of the body. So the 2 main types of local therapy are surgery and radiation therapy. And these treatments are more useful for colorectal cancers when they're in their earlier stages. So they're less advanced. They have not progressed to for instance, a stage 4, where it's now spread to other organs. Systemic treatments are typically drugs which can be given by mouth or directly into the bloodstream. These types of therapies can reach cancer cells anywhere in the body. So the 2 main types are chemotherapy, which are anti-cancer drugs. And then there are also these targeted therapies, which are newer drugs that target genes and proteins in the cell that cause cancer. Because of their targeted action, these drugs have an effect on the cancer cells, and they mostly leave your normal, healthy cells alone. Traditional chemotherapy is what we call the way to think of it is that it's cytotoxic to most cells, meaning that not only is it damaging and killing cancer cells, but it can also damage your normal, healthy cells. Your treatment team, so patients that have colorectal cancer will have a lot of people involved in their care. So a gastroenterologist, such as myself, we typically are the ones that find the colorectal cancer. We make the diagnosis at the time of a colonoscopy. Patients will then be referred to oncologists as well as surgeons. Depending on your institution, you may see a surgical oncologist or a colorectal surgeon. These are doctors who use surgery to treat the cancer, whether it's in the colon or the rectum. A radiation oncologist treats the cancer with radiation therapy. A medical oncologist is a doctor who treats the cancer with medication, such as chemotherapy or with targeted therapy. Other people on the treatment team may include physician assistants, nurse practitioners, nurses, psychologists, social workers, and nutritionists. So you can see that the treatment of colorectal cancer, it's not just with one doctor. It's really a team-based approach. A lot of specialists are involved in these patients' care. In regards to survival rates, so we like to look at 5-year survival rates. So that's the percentage of people who survive at least 5 years after a cancer is found. So if cancer is confined to the colon or rectum, which is in early stage, the 5-year survival rate is 90%. when the colon starts to spread, especially outside the colon, that 5-year survival rate will start to come down. So colon cancer, which has spread to surrounding tissue, there's a 70% 5-year survival rate. And then the 5-year survival rate drops all the way down to 12% if the cancer is found after it has spread to distant organs. So that's typically going to be your stage 4. Now, in patients who have been diagnosed with colorectal cancer and have undergone treatment, what happens as a cancer survivor? So even in patients that are in remission or who had successful treatment, you still have to go and see your doctor. So you will still be undergoing colonoscopies. You will have a colonoscopy 1 year after your surgery for colorectal cancer, and that's really to make sure that there's no residual cancer and no new development of any cancer in the colon. We also look for any new development of polyps, and if we find them, we remove them. If that colonoscopy 1 year after surgery is normal, we can start to space apart your future colonoscopies. You can expect to have your next one in 3 years. And if that's a normal exam, then you'll be spaced out to about every 5 years. In regards to imaging tests such as CT scans, the medical oncologist really helps with that in terms of recommending whether any imaging tests will be needed. And it really depends on what the stage of your colorectal cancer was. And then finally, we do use blood test for tumor markers. So there is a blood test called a carcinoembryonic antigen. It's known as a CEA test. And it's a substance called a tumor marker that can be found in the blood of people with colon cancer. And when people have colon cancer, typically that CEA is quite elevated. And then after successful treatment, that CEA is still monitored and you'll see it come down. And for those people that are familiar with the PSA, or which is the tumor marker for prostate cancer, it's a very similar way that this CEA works. It's a very similar thought process. So again, it does not diagnose the cancer, but it is a good test to follow along in patients that have cancer and then have been treated, because you will see that tumor marker start to come down. Now, there are cancer concerns even after treatment. So colorectal cancer survivors can be affected by a number of health problems, but a major concern is going to be facing cancer again. So cancer that comes back after treatment is called a recurrence. Some cancer survivors develop a completely new, unrelated cancer later on in life, and that's called a second cancer. People who have had colorectal cancer can still get the same types of cancers that other people get. In fact, they might be at higher risk for certain types of cancer. So in somebody who has colorectal cancer, it's still important to continue your other screening tests, whether that's your, for instance, your mammograms. And then just to kind of end the presentation, I wanted to go through some statistics, some colorectal cancer statistics. So on average, the recommended frequency of colonoscopies is every 5 to 10 years. If there are no polyps found in a colonoscopy, the patient has no family history, no personal history of previous polyps or colon cancer, you can go to 10 years. If somebody has polyps, especially precancerous polyps, you could be looking at 5 years. Once in a while, somebody does need a 3-year follow-up, and that's typically in somebody who has multiple precancerous or adenomatous, otherwise known as adenomatous polyps. March 3rd is National Colon Cancer Screening Day. You only need one colonoscopy in which colon cancer can be detected and prevented. This number is a little bit old, but it's still a pretty high number. So about 40% of at-risk Americans are not getting screened for colon cancer. So again, we still have a ways to go to get people screened. The survival rate, that 5-year survival rate of colorectal cancer when it is caught at an early stage is 90%. That's a great survival rate. The average time length of a colonoscopy is about 30 minutes. However, if it's somebody that's got a lot of polyps, you can start to see colonoscopy at about 45 to even 60 minutes. But again, that's rare. I'll tell you on average, it's about 30 minutes. You have a 1 in 20 chance of developing colorectal cancer in your lifetime. Again, we are pushing to start the screening age at 45. We are seeing that may become the new average risk for colorectal cancer in men and women. And there are more than 1 million colon cancer survivors in the United States. The resources that I used to put together the presentation come from a variety of sources, including the American Cancer Society. I left off the American College of Gastroenterology, but that's one as well. We have the AGA, American Gastroenterological Association, the Society for Gastrointestinal Endoscopy, the Centers for Disease Control and Prevention, Colon Cancer Alliance, the National Cancer Institute, and then StopColonCancerNow.com. So that concludes my presentation. Thank you so much for listening. And Dr. Dhananjay, I don't know if how I'm doing on time.
Oh yeah, actually, we're very good on time. We have 10 more minutes.
Okay.
We can take a few questions.
Okay.
So that was a very great informative presentation.
Thank you.
Thank you. Thank you for your time. And going to the first question from the audience, is the increased incidence of colon cancer in less than 50 years age is due to increased in screening or due to increased disease occurrence?
Okay, so the question is, why is there an increased incidence of colon cancer in people less than 50?
Yes. Is it because you're screening them more often, or is it because it's a true disease increase in occurrence?
I see. No, it is a true increase in the occurrence. We do see younger people developing colon cancers. It's not so much that we're just screening more and more and picking it up. We are seeing these precancerous polyps grow in younger people, and a lot of times they don't have a family history. They cannot identify, that this runs in the family. So what that sometimes indicates, or what we think, is that is this something to do with our environment and our lifestyle? Is this related to how we live, how we eat, that we're seeing these precancerous polyps and colon cancers now start to develop in younger people?
Okay, yes, yeah, that makes sense. And you did explain the options of screening, and I know the gold standard is colonoscopy.
Correct.
What if the patients, they want to explore other options like capsule endoscopy?
So capsule endoscopy is a good test for identifying, more for diagnostic purposes. It is not used to find polyps or cancer in the colon. I'll give you an example of where capsule endoscopy comes in useful. It comes in useful in somebody who is bleeding and you cannot identify the source from the stomach or from the large intestine, so from the colon or the rectum. That does leave your small bowel or small intestine, which is a little bit of a difficult area for us to get to with our scope test. That's where a capsule comes in handy to investigate that area of the digestive tract, but it's not a good test to look for polyps. It's not used for that.
Yes, thank you for that. And I think Dr. Bhupal will take the few other questions.
So thank you. We have another audience question.
Mm-hmm.
I am 72. I am scheduled to have my third colonoscopy in the fall.
Okay.
The last time I had one was 5 years ago. A couple of polyps were found, but not cancerous.
Okay.
I had a hard time with the prep the night before.
Okay.
Are there better products now available? Do you have to drink all that horrid liquid if you do not eat for 2 days, but liquid?
Yes. So, there's no, great way to clean out the bowels. Whoever can figure out an easy way will be a billionaire. They really will, because all these years you still have to get rid of that stool somehow. But in terms of how we prep people, the first is if somebody does not have any underlying kidney issues, they could be a candidate for different types or smaller volume preps. The generic prep is still the gallon bottle. And it comes in all different types of names: Go Lightly, New Lightly, Co Lightly. It comes with flavoring, but you can mix whatever flavoring you want. I know it's horrible. The smaller volume preps do use some of them. Clenpec is, I think each bottle is about 5.4 ounces. Then Suprep is a 6-ounce bottle. Each bottle is 6 ounces. It's followed by large glasses of plain water. So you end up drinking a lot more plain water and a lot less laxative. So it is a little bit easier for people. There's another prep out on the market, which are tablets, which is followed by a lot of water. Again, this is safe typically in people that don't have any underlying kidney disease. You can even do a concoction of over-the-counter medications to prep, even as something as easy as Miralax, magnesium citrate, and Dulcolax tablets. You can do a homemade prep. So, there are different ways to prep. We do tell patients, especially if the prep is what's holding up people from getting their colonoscopies, we gastroenterologists, their team will work with the patient to try to find a way to help them get through the prep. So you do have several options. You're not just limited to the gallon of laxative anymore.
Thank you, Dr. Patel. I'm sure that a lot of people are happy to hear that, because people tell me the prep is worse than the scope.
Yeah, it is. The preparation is worse than the actual day of the procedure. Yeah, that goes by fast. It's the prep. Yeah.
All right, thank you. So the next question is on our gastrointestinal tract, not necessarily the colon. So I developed GERD shortly after eating some seafood that I left out overnight.
Mm-hmm.
I was just diagnosed with gastritis and was wondering why it was so hard to treat GERD or acid reflux. I have become a vegan and take a PPI twice a day. I am feeling much better since doubling my prescription, but worry about taking a PPI long-term because of side effects.
Sure. Yeah, no, so if you've developed the classic symptoms of GERD and you're responding to a PPI, we do see sometimes that a PPI once a day, it may help to control the symptoms, but not fully. So it's fair to double it to twice a day. We do recommend, giving yourself a trial on the twice a day PPI. So do it for about 3 months. And then you are fine to decrease it back down to once a day and see how you feel. But remember, you've also got to do that in conjunction with dietary and lifestyle changes. That's really what's going to get you the furthest, and so that you don't have to rely so much on medication. Sometimes people use these PPIs and they kind of think of it as a magic pill, and that's not what it is. It's really changing your diet and lifestyle.
Excellent, thank you.
Mm-hmm.
One more question on the colon cancer risk.
Mm-hmm.
Does eating barbecue or grilled meat rather than oven cooked increase cancer risk?
Yeah, so there is a concern that grilling meats can, and this is really, not just once in a while, but regular use of grilling meat or barbecuing can increase the risk of adenomatous or precancerous polyps in colon cancer. So yes, there is some thought that grilling and barbecuing is linked to colorectal cancer. Again, I tell people that you can eat what you want. For instance, you can eat red meat, you can eat processed foods, but you really have to have a good balance in your diet. If that's really what you're relying on and eating all the time, it's not healthy from a colon standpoint, but also from other organ systems as well, like your heart. But yeah, to answer your question, there is thought to be a link between barbecuing and grilling, that it could be a risk factor.
So the next question is, how long it takes from prep to develop cancer? I'm assuming it means from polyp to develop cancer.
Typically, so for the average person, it takes a few years. It's not something that happens overnight. It can take several years. In people that may have a genetic risk factor, we do see sometimes that these polyps can be very aggressive. For instance, we may have somebody with a large polyp that we're removing piecemeal, meaning that we can't remove everything at one time. We have to go back in a few times to remove it piece by piece by piece. And we can see that polyp is aggressive. It's growing every time we go back in there. We can see that it's grown a little bit more. We have to remove a little bit more each time until we get it out. But for the average person, it takes time. Colon cancer is slow growing.
Excellent. And, that brings up a great point. If you're 52, if you're 53, if you've not had screening, do it now, because it does take time to, the earlier you do it, the earlier we catch, the more we find, but there is no wrong time to do it.
Right. And you have to realize that these polyps, they start out at 1 millimeter, less than 1 millimeter. We see them because everything is magnified at the time of the colonoscopy. We are removing polyps that are precancerous, so they have not turned into a cancerous, even at 2 centimeters. That's 20 millimeters. So to go from a 1 millimeter size all the way to a 20 millimeter size, it takes a long time. And we can still remove them at the time of colonoscopy. But once you start to get a lot bigger than that, that's when we have to refer you to a surgeon, or that's when it's already turned into a cancer.
Excellent. So, okay, one more question. Once polyps are found, how often should we go for colonoscopy?
So if you have a polyp, even if you have one polyp that's found, and that polyp is an adenoma, so a precancerous polyp, we do tell people 5 years, and there is some buzz that it may even get bumped to 7 years, but I would still stick with 5 years to do your next one. If you have a large polyp that's 1 centimeter or greater, that's a precancerous polyp, or you have several small polyps, but they all have to be precancerous, we may tell you to come back in 3 years for your next colonoscopy. So it depends on whether that polyp is precancerous, how many of them are there, and the size of that polyp.
Excellent. And again, like you pointed out in your talk, it depends on the polyp. If it's a hyperplastic polyp, then you probably don't need to change your frequency at all.
Correct.
Okay. All right. I think that is the end of our questions. Here's a comment. Thank you, doctors. Great presentation. I'm grateful for your time and love for humanity.
Thank you. That's nice.
Thank you, audience. Thank you for tuning in, and thank you for your participation. That was lovely. Dr. Patel, thank you for your talk. I learned a lot, and it was excellent.
Thank you.
Audience, we are still in the middle of the pandemic. So please, we have to continue to maintain the CDC recommended guidelines to wear masks, social distancing. For those of you who have received the COVID vaccination, thank you. You've taken the step in the right direction. For those of you who've not, COVID vaccination is opening up. It's more available. So go ahead and get the vaccination. If you have any questions on the vaccination, on your individual health, please reach out to your healthcare provider to get those answered. But Dr. Patel, you told us why we should be thinking beyond the pandemic, beyond what COVID is doing, because we do have to take care of our entire body. We have to, definitely. So make sure you're getting your exercise. It's getting nice outside. You can go out, take a walk, eat right. It helps you with colon health. It helps you with diabetes, high blood pressure. It helps you all the way around. And don't forget your mental health. Make sure you reach out to a friend, a colleague, a neighbor, your healthcare professional. Take care of yourselves on the whole and be the best possible versions that you can be, and go out and conquer the world. So thank you all, and good night.